So today I'm grateful for a couple of things. One is all of your time. I know you're all very busy people who have clinics and other things you could be doing, things with your family. And to have 20 minutes or 25 minutes to spend chatting with you is a privilege. I'm also very grateful for all of you as colleagues. I'm talking a bit about civility across specialties. And I feel like working at KGH is a real privilege with a lot of consultant colleagues who are fantastic, who are friends, who are people that we all kind of work together to do the best we can for patients. And so thank you for that. So before I get into the content here, I just wanted to invite everybody to go back to your first day that you were at medical school or nurse practitioner school, midwifery school, dentistry, and how that felt. Thinking back to orientation week or whatever your school called it, I remember I was sitting on the grass outside of Botterill Hall on the Queen's University campus, and we were all broken into small groups, and just looking around at all the people around me and feeling like, oh, I made it. This is so exciting. You know, all the work that you put in, and now you're actually going to be a doctor eventually. And everybody came from different parts in the country, different backgrounds, different interests. And most people didn't really know exactly what they wanted to be. They were kind of undifferentiated stem cells, so to speak. And I thought that was a really amazing time. We're all working together to eventually be physicians, not knowing yet what we're going to do. Fast forward a couple of years, and maybe you've started a clerkship rotation, and you are maybe experiencing some of the things I did at that time. There's lots of excitement caring for patients and learning how to actually do that. But maybe you're on an emergency medicine rotation and you overhear a preceptor saying, I can't imagine ever being an internal medicine specialist. They just talk about problems and don't solve them. Or you're in the OR and maybe somebody says, I'd never want to be an emerge doc. They just triage, right? There's all these little hidden curriculum things that come out in clerkship. And then fast forward a couple of years and now you're in residency and that emerge doc's calling you for the 10th time. It's 4 a.m, you've had no sleep. And it can feel like that person is out to get you. They just keep shoveling you work all the time. And it's not hard to imagine, fast forward again to life as a staff physician, your family, you've got pressures financially, you've got maybe your kids aren't acting the way you wish they did. There's a lot of things that can go on, and it's pretty easy to imagine how incivility can creep in to our workspaces on a daily basis. So that's what got me interested in this topic. I had the privilege of being part of the Navigate Cohort 3, and my project was on civility between physicians in the context of a consultant relationship. So I'm going to talk a bit about that. I don't have any disclosures. I would ask for shared fallibility because I'm not an expert on this. This is something that's just interesting to me, and I did a little project on it. I'm going to talk to you a little bit about my findings, but I am no expert, and I have many days where I speak to even some of you in the room about a patient that I'm hoping for your help, and I hang up the phone after. I'm like, oh man, I wish I did that differently. So definitely not an expert, and I'm learning all the time. I'm hoping to start by just getting a bit of a definition of what civility is. This morning in Lisa and Erica's talk, they went over this a little bit as well. But it can be a confusing term, and I've actually heard some people reflect on how they don't even love the word because it can almost have like colonial kind of implications. I don't mean it in that way at all. I'm going to be working from this definition, so I'll give you a sec to read that. So we've heard a bit this morning about why this matters already. From my perspective, and some of what came out in the survey data on my project, incivility is rarely intentional. I don't think anybody sets out at the beginning of their day to make somebody else's day not great, or to be unhelpful, or to be any other form of incivility. What's universal to all of us is that we have high workloads, we're being interrupted a lot, and as Cecile said, big, heavy machines will crush you. And so we all work in that environment. And that's why this matters. Lastly, and perhaps most importantly, incivility affects our patients. And at the end of the day, every conversation we have between each other as physicians or other medical staff is usually around patient care. And when that breaks down, then the patient suffers. So that's why this matters to me. So to give you a bit of a background on my project, this was a survey that was done within KGH, but I think it has implications throughout the health authority at acute care sites. I used a methodology called positive deviance, and the idea there was to actually identify what practices are helpful in promoting civility instead of just focusing on what takes away from it. And I was really pleased that about 36 of my colleagues responded to this survey. There was a good mix between the 3 different specialty groups that I surveyed. There was no specific reason why I picked these 3, emergency medicine, cardiology, and the hospitalist group, aside from the fact that we interact with each other frequently, those 3 groups, and so I thought it would give a nice little snapshot into this. About 50% of the respondents were emergency medicine physicians, 25% were hospitalists, and 25% from cardiology. All people who are practicing staff physicians in high acuity clinical environments with a lot of frequent consults, interruptions, and pressures. So for the next 15, 20 minutes, my goal is simply to get us thinking about our role in culture development and civility between physicians and medical staff in our health authority. We're going to talk about kind of 3 basic stages in what my project highlighted, which is before the consult discussion, during the discussion, and after the discussion, what you can do for follow-up when things might not go the way you hope. So civility definitely starts before a phone call is made or before that interaction that happens on your desk side. I think preparation is respect, and this came out very strongly in the survey data. It was the most consistent civility behavior that was identified, for sure. And so things like reviewing the chart first, knowing your key lab and imaging findings, the overall trajectory of the patient, are all things that are really nice to know before you set out to have that consult discussion. And I am going to talk about this from the role of the person calling and the person receiving as well, because those are 2 important roles equally. And preparation communicates competence. So I think when we'll talk a little bit later about kind of basic assumptions about competence that we have for each other, and I think preparation is one of the things that help to build that. To open the interaction, in the first 10 seconds, it really sets the tone. There's lots of literature on first impressions and the kind of first little bit of time when you meet somebody, forming kind of your opinion overall. And so I think the first 10 seconds kind of agrees with that. Using names was a theme that came out in the data quite a bit. And people at KGH anyway, I find there's a lot of using of first names. Not everybody agrees with that, but I think that's a really nice touch to level the playing field and have everybody feeling like we're colleagues and that there's not a hierarchy or a power differential. Having some sort of brief human acknowledgement is nice. People tended to not love the how's it going because it tends to be a little bit canned sometimes and not feel as authentic, and yet that's what I often do. Pick up the phone, I'm like, hey, how are you? But sometimes getting a little bit more creative, trying to make a connection on something that happened recently in that person's life or in your life or something like that is nice. And some sort of acknowledgement, like thanks for calling back. We're going to talk a little bit about whether one should apologize for calling next. That was a really interesting question for me, and I actually specifically put it in the survey because I think it's controversial and I love controversial stuff. So there's no single right answer to this question. What I found really fascinating was out of the 36 people that replied, it was almost exactly 50-50 between people who thought one should apologize and people who thought you shouldn't. And then amongst those, there's sort of 2 camps. The first was no apologies needed because consulting is that person's job, so why am I saying sorry? The next was that it's context dependent, so the people who thought apologizing was nice were thinking, well, it depends. What's the timing? Is it 2 in the morning or is it 2 in the afternoon? Volume matters too. So is this the 10th time I'm phoning that person or the first time? And so there's maybe some subtlety to it. Ultimately, the theme amongst both the camps of should I or shouldn't I was that empathy de-escalates. And so if we can imagine ourselves in the shoes of the person we're calling and vice versa, and empathize appropriately, that's going to de-escalate tension 100% of the time. And authenticity matters more than a script for this. So I think whatever we're doing, again, just being cognizant of the timing and the volume, as that second point says, is probably going to be more important than a script for 100% of the time. Ultimately, whether you choose to apologize or not, or whether you prefer to be apologized to or not. I think that we do need to work towards leveling the playing field. Tone is definitely a cultural signal, and the tone with which we speak to each other kind of sets the culture at our institutions and within our health authority. And certainly feeling talked down to escalates conflict. And so civility improves when physicians feel respected as equals, and this was very strong in the data that I had in my survey. And whether you're somebody who's trained in family medicine, whether you're trained in emergency medicine, whether you've done a 6-year fellowship or a 6-year residency and 2 fellowships, it doesn't really matter. Ultimately, we're all people that have a certain skill set within what we do that deserves respect, and that ultimately, if someone's phoning you, they're calling you for help with the patient in front of them, right? And that's at the end of the day what matters. So I think leveling the playing field is one way that we can build civility into our culture. So getting a little bit into the actual meat of the conversation. So everybody agreed that having some sort of clarity on what you're requesting early in the consult request is really key. So is this for advice only, telephone consult? Is this an in-person consult where you'd like the person to come to emergency or to come to the OR, come to the ward? Is this for outpatient follow-up? And clarifying urgency early is really helpful. Certainly as an emerge doc, if I'm phoning someone and I would like them to be there right now because this is a critical situation, I'm going to try to lead with that. If it's something where it's going to be a week down the road or 2 weeks down the road, it's nice to also lead with that so that the person knows that they don't necessarily need to rush either in from home or down from the ward right away. So I talked about how this is a bit of a two-way street. So there's equal responsibility on both sides of the phone here. So we'll talk a little bit about when you're receiving a consult as well. Ultimately, your response communicates psychological safety. And I had the privilege of the first 2 talks really unpacking what that means already, so I don't have to go too much into that. But really the response will create that environment that has respect for colleagues and has colleagues feeling empowered to be able to call you for help when they need to, rather than fearing making that call or avoiding it, and therefore impacting patient care. So in terms of that positive deviance, the things that are helping with civility on the other side of the phone, certainly having a respectful tone was really, really helpful, and especially during disagreements, because you don't have to always agree to have civility, and civility doesn't necessarily mean being sort of soft or those soft skills. You can be assertive, you can have an opinion, but being respectful about it is key. Interestingly, amongst the emergency physician side of the survey, there was a desire for recognition of emergency department workload and uncertainty. I think what this is getting at when I was reflecting on it isn't so much that we're uniquely busy, because all of us are busy, but it's the uncertainty piece that makes emergency medicine particularly challenging from that perspective of we have no idea what's going to come through the door. We have sometimes we don't even know the diagnosis right away, right? We're trying to start working things up, but we've got someone who's unstable. And that recognition of that uncertainty is really helpful. Also, clear guidance without dismissiveness was highlighted. And so I think this builds into the 4th point too of problem solving. Occasionally, when there's a talk about a patient going on between 2 people that are caring for that patient, or there might be a disagreement about the best way forward. So maybe that consultant's not the best person to actually take over care and somebody else is. Or maybe there's a piece of advice that somebody else needs to weigh in on. And rather than sort of dismissing that and saying you're calling the wrong person, call so-and-so, and it being kind of abrupt, it can be really helpful to problem solve together and say, okay, well, I can hear that you've got a patient in front of you who's, got a GI bleed and their hemoglobin's dropping. I don't feel like I'm the best person to deal with this, so let's talk about how best we can get this problem solved. That type of thing is really, really helpful. Despite the positive deviance methodology, there's obviously still some comments that were made on things that are unhelpful, so I thought I'd highlight those as well. Some of these are kind of obvious, but they can come into play insidiously when we're tired and overburdened and all the things we've talked about. So dismissive tone or sarcasm was a big one. Questioning competence rather than clinical reasoning, and escalating tension instead of clarifying the issue. And I think they're all self-explanatory. I probably don't need to unpack those too much. But inevitably, when things do get hard and when we're very, very busy and fatigue and volume are overpowering, or when we're having our kind of worst days, which we all do, there were 3 different strategies that came out as signals in the data about what we can do to mitigate that. And one of them was talked about already, I think, in both Cecile's talk and the CMPA talk, which is to pause before responding. And even if that just means taking a deep breath, not a sigh, but a deep breath, and 2 or 3 seconds, and then kind of jumping into what you're going to say, it can be as simple as that, and that can really, really help with recentering. And then resetting the tone intentionally and refocusing on shared patient goals. And I found that one to be quite effective a number of times personally, and I've heard colleagues do it as well, where maybe you're not quite getting anywhere, and just to say, hey, it sounds like we're maybe on different pages right now, but this is the problem, this is the patient I have in front of me, and what I'm hoping we can do, and kind of recentering on that. So the follow-up piece, if things don't go as you would hope they would, is really, really important. I think it's an often missed opportunity in our busy clinical lives, where if things didn't go as well as you wanted them to, you can follow up with that person later, right? Even if it's not in that exact moment when things are super busy, it could be the next day, it could be even a week later. You pick up the phone or write an email or text them or whatever and just saying, hey, like, I felt like that interaction didn't go as well as it could have. Are things okay? Are there things I could do differently next time? And in the few times that I've done this, I've found that it has been a very effective way to build bridges, to build better connection, and ultimately to change those interactions moving forward. So I encourage everybody to follow up afterwards, even if it doesn't go well the first time. So I'm hoping to make this last bit a little bit interactive. I put together a couple of quick cases. The idea is just to sort of identify some tension points and then how we might handle those. And these are obviously through my biased emergency physician lens. So this first one is, it's 1 in the morning in the KGH emergency department, and you've got a 45-year-old patient with CT-confirmed appendicitis. And pain has improved with analgesia, vital signs are normal. There's not necessarily an urgency for this person to go to the OR right now. And the surgeon that's on is covering the OR and consults and had a busy evening, and they're now at home. They're not doing in-house call. And the ED is already boarding 40 admitted patients. So then on the other side, you're getting pressure to fill out admission orders and get this patient moving up to the ward so that we don't have bed block issues. So what are some key tension points going on here, like that could prime this for a challenging interaction? Dima?
1 a.m. and it doesn't really sound like a medical emergency that requires probably not call necessarily,
Right.
but maybe if it was someone who you're talking with, you might call them.
Yep, good point. Anybody else?
My shift, oh, it was super. My shift ends at 1 a.m. I don't go there.
Yes. That is a key tension point. Yeah, so there's a number of things that set this up for a potential challenge. So, and Neil, I appreciate you bringing that up because it's one I didn't actually have here, but it's one we experience all the time. So does this patient need immediate admission, and is overnight surgery necessary? And how do we actually balance ED pressure in terms of bed and volume and that kind of stuff with surgical workflow? I think at the end of the day, this is one of those it depends types of situations, because and again, the whole apologize question, it came up like, what's the volume been? What time of day is it? And I think that matters here. Because if you know, for example, that your general surgical colleague was just in the emerge at 12:30 and now it's 30 minutes later and they're probably not in bed and asleep yet, and you could conceivably have a conversation and address both concerns, perfect. But if it's 1 in the morning and they've been home for 2 hours and you don't necessarily need them to go to the OR right now, that might be a conversation that can happen in 5 or 6 hours, right? So I think we can have some subtlety to this, and I think we do try to do that in our environment at KGH. Okay, so I think in the interest of time, because I've got just a couple minutes, is that right? Yeah, 11:55. Okay, cool. So I'm just going to move through this second one just to get to the last bit here. Another thing that came out in the survey that I didn't anticipate because it wasn't part of my formal questions, but that I thought was so important, is how your influence in this realm is amplified. So trainees copy what they see, and we know that these patterns will persist, and the culture that's built within residency programs and training programs often follows those people to where they go to work. And so I think as a training center here and other training centers within our health authority, we have to be really cautious of what kind of culture that we're propagating around civility between physicians. And I would argue that culture spreads faster than policy. And so I think those little interactions we have on a multiple basis per shift or per day or even per week are really setting the culture in our institution. And so we need to be cognizant of that. So I want to end by acknowledging that we're all very busy. We work very hard. We're all tired. And we're all dealing with constant interruptions. And yet most of the time, we are all trying to do our best and do the right thing for our patients. What my survey data shows is not that we have a civility problem necessarily within KGH or within our health authority, but rather when things don't go well, it's usually that we're working inside a system that's stretching us. And as Cecile really nicely highlighted, is causing pressures that are really unsustainable in a lot of ways. And how we treat each other and how we speak to each other, in my mind, is one of the few parts of that system we can still control. And so I think that's why this matters. It's not about being pleasant necessarily, it's about being reliable, especially on our worst days, and treating every consult like a leadership moment because people are watching, and every time we receive a call or make a call, we're kind of setting up that little interaction that's going to set the culture in our institution. And so my ask, what I want to leave with you guys today, is that if you're requesting a consult, maybe prepare a little more than you normally would, and open the conversation like you're talking to a colleague you respect, and be clear about what you're asking and why. And then on the other side of the phone, when you're receiving a consult, maybe pause before you respond. Assume good intent of the person that's on the other side of the phone. And even if you disagree or there's something that could be done differently, setting boundaries clearly without dismissiveness is really, really helpful. Because I think the culture of our institution and of our health authority isn't set by policies or emails, but it's the thousands of short interactions that are happening constantly within our workplaces. Thank you.